Good morning, everyone, and welcome to the Grand Rounds for Thanksgiving week. Before Dr. Lesser introduces Dr. Cheng, I just wanted to call out one of our studies. This is actually a pharmacologic study in the ICU under the direction of Dr. Ramiro Saavedra. MHIF is collaborating with him. The study's name is KPL 301C203, which is shorthand. It's a pharmaceutical trial sponsored by Canixa. The drug is mavrilimumab, which is an antibody directed at one of the inflammatory components of the COVID infection. Specifically, it's the granulocyte macrophage colony stimulating factor that it's directed against. This drug has been used in Italy in a small number of patients where the mortality was 0% in highly ill patients versus 27% in the control. So the results were very favorable. The drug is an IV infusion over about 1 hour. And we've entered, since October, we've entered 4 patients. All of the patients have survived. The criteria are you have to be quite ill, bilateral pneumonia on either X-ray or CT, and evidence of hyperinflammation, either with elevation in ferritin, a CRP D-dimer, or other components. Christine Majewski is running the trial in cooperation with Dr. Saavedra, and so we will welcome any patients that you might have. This morning, I want to, before we introduce Dr. Cheng, I want to thank the Janssen Pharmaceutical folks, our friends who support us with Xarelto, and also Janssen Pulmonary Hypertension, which is used to be Actelion until 2 months ago. So thank you to you guys for your continued support. And now I'll call up Dr. Lesser, who will introduce Dr. Cheng.
Hi, well, it's really a pleasure to talk about Dr. Victor Cheng today. He is, as you already know, a wonderfully good cardiologist with a very good sense of humor. But his most important thing, he was a reserve point guard. It was at a high school. And then things went downhill after that. He went to Northwestern. And after Northwestern, UCSF in internal medicine, and then Cedars-Sinai in cardiology, where he stayed on and did a lot of important work in coronaries, non-invasive assessment of coronary plaque. And I think there's a huge amount going on in that field that Dr. Cheng's been a large part of, and he's part of our team now. So I'd like to introduce him and we'll learn a lot. So thank you.
Good morning, and thank you, John, for the kind introduction. For this grand rounds, my goal is to show you an argument that coronary plaque imaging by CT represents the next big frontier for diagnostic management of coronary artery disease. I don't have any disclosures, and I will just go through a quick outline of what the talk will be about. First, I will go through a description of coronary CTA in the view of a stenosis-based paradigm. Follow that up with discussion of thin cap fibroatheroma, which I will pronounce from now on as TICFA. Take a look at CTA imaging of TICFA features and risk. Look at some challenges in real-life measurement of CTA plaque findings. Discuss application of plaque categorization when it comes to patient care, and finish with some uncertainties. As MHI CTA readers, this is a pretty common scenario for us. We're sitting in the reading room and a colleague from the inpatient service has stopped by to ask to take a look at the coronary CT angiogram that has been done in one of his or her patients. And no matter how the question is asked, we're generally asked to answer one major question, which is If we proceed with invasive angiography, will invasive angiography of my patient show obstructive culprit disease? It has been 14 years since CTA has gone live with the 64-slide scanner in 2006, and still the field is dominated clinically by the use of the stenosis model. That is there obstructive disease or not? CTA is kind of considered cath-like, the little brother to catheter angiography, with accuracy verified by comparisons to cath. Absence of greater than 50% diameter stenosis has been shown repeatedly to exclude epicardial disease as the cause of outpatient symptoms, safely excludes acute coronary syndrome in intermediate probability symptomatic patients in the emergency room and the hospital, excludes coronary disease and the need for catheterization before non-coronary cardiac surgery, and excludes coronary disease as the cause of cardiomyopathy, among other uses. We know this paradigm works. This paradigm has been verified by high-quality studies in the emergency room that shows us we can expedite discharge safely. Important diagnostic strategy studies in Promise and Scott Hart that shows CTA-based outpatient management is at least as safe as functional testing-based management, and also to discover additional utility of CTA in the landmark trial Ischemia published earlier this year. The stenosis paradigm is so strong, it has earned CTA first-line recommendation for diagnostic testing for coronary disease in the United Kingdom, from the European Society of Cardiology, in Australia, and in the United States, our experts are pushing for the same. At the same time, we realize that using a stenosis paradigm ignores a lot of patients. You probably have heard from previous settings that non-obstructive plaque actually are the ones that develop into the majority of future culprit lesions that cause myocardial infarctions. Estimates vary, but have gone anywhere from 50 to 70% in general. And this idea has been around for decades. This one particular study I'm citing comes from 1988. It's a catheter angiogram-based study just in 42 consecutive patients with acute myocardial infarction who happened to have had a cath prior to having had the myocardial infarction and then had another one as a result of the myocardial infarction. And in this study, the research team could not find a relationship to the amount of stenosis that was seen on the previous cath as to whether or not that lesion will develop into the myocardial infarction lesion. And there was no relationship to amount of stenosis seen at the time of the prior cath to the amount of time it took for the patient to have a myocardial infarction. Now we fast forward to 2011 and look at the landmark Prospect trial. And this was a cohort study of 697 patients who experienced acute coronary syndrome and then consented to undergo 3-vessel intravascular ultrasound, IVUS for short, during their diagnostic and interventional cardiac catheterization. The follow-up was for a median of 3.4 years for the outcome of cardiac death, myocardial infarction, cardiac arrest, and angina requiring hospitalization. What we see in the follow-up is that nearly half of the subsequent events occurred in non-culprit plaques compared to when the patient had their first cath, with the other half coming from the target lesion that was intervened on. And the mean, importantly, the areas that subsequently caused a myocardial infarction all show some plaque on IVUS. And most of these plaques were non-obstructive. The mean diameter stenosis of these plaques were 32%. There's plenty of other data showing the importance of non-obstructive plaque as becoming the subsequent lesion causing problems. This is an inference study from the CONFIRM registry of 24,000 patients. It's a multinational study at 12 centers in 6 countries. Median follow-up was not very long, just 2 years. And during that time, 404 all-cause deaths were recorded. And in this study, could see that the non-obstructive disease patients had an event rate, had died as often as patients with one artery obstructive disease. And as expected, number of patients with non-obstructive disease far outnumber patients with obstructive disease. This is a study in 3,200 patients, consecutively imaged with coronary CT angiogram. Got my mic there. Consecutively imaged by the CT angiogram with no history of coronary events in the past. And these patients were followed up for a median of 3.6 years. And what the authors found was that if you take a look at the number of coronary artery segments with plaque, patients with 4 or more segments with plaque, so those would be the orange bars with the orange arrows over them, had experienced a higher rate of cardiovascular death or myocardial infarction, and a higher rate of all-cause death compared to patients with obstructive plaque, but less than 4 segments of plaque. So those would be the red bars right next to the orange bars. Similar information was found in the PROMISE trial. Again, as a refresher, this was a strategy trial comparing 4,500 patients randomized to CT angiogram as the initial diagnostic test to 4,600 patients in whom functional testing was the initial diagnostic test. Patients were followed for a median of 26 months for all-cause death, cardiovascular death, myocardial infarction, and unstable angina. In this post hoc analysis, the team dived deeper into who ended up having the events. And in the patients randomized to CT angiogram, 77% of cardiovascular death and MI occurred in patients with non-obstructive disease. Did we see something similar, since this was a randomized trial, in patients with functional testing? And indeed, we did see that. In the functional testing arm, 67% of events happened in patients with a baseline normal testing result. So the bottom line from all these studies and similar studies is that we know before a coronary event, patients can produce normal results on functional testing, but their coronary arteries almost always show some plaque on CTA. To put it in another way, it looks like CTA is the only non-invasive modality that can possibly find the eventual culprit non-obstructive plaque. Now we know CTA sees lots of different types of plaque. Take a look at this right coronary artery here. I've made a still picture of it in the middle, and it looks like on the angiogram, the area where the green arrow points to is where the plaque is. Except on the CTA, we see that there's no plaque there. The plaque is actually on the opposite side of the artery to cause the visual narrowing. The blue arrow points to a different region of plaque that may or may not have been noted at the time of invasive luminography. This is a left anterior descending artery that looks quite normal and likely would be called normal frequently off of the report, but we see multiple sites of plaque as shown by the orange arrows on the top right panel. In this left anterior descending artery, certainly the narrowing in the mid segment would be called, and that is highlighted with the plaque, prominent looking plaque there on the right panel with the orange arrow. There are also other sites of plaque that are not nearly as apparent on invasive luminography. So we'll start with understanding a little bit of the basic plaque categorization on CTA. And there are 3 basic categories of plaque. Calcified plaque, I'll back up first. If you're not familiar with CT angiography, the coronary arteries have contrast filling them, and they look like light gray colored winding rivers going down the picture. Calcified plaques appear bright and white, and they are in this picture exemplified by the yellow arrows. Non-calcified plaques look like dark bites off of the side of the artery, and the red arrow points to a small one on the right. And partially calcified plaques have features of both in the dotted orange oval. Calcium scans that some of our patients get can only see calcified plaques and calcified parts of partially calcified plaques. It cannot see non-calcified plaques. How prevalent is non-obstructive plaque? Well, we have some recent data to show that it is incredibly prevalent. About a week ago at the American Heart Association, a Swedish team presented initial data from the Swedish cardiopulmonary bioimage study. Acronym is SCAPAS. And this was a tremendous undertaking, enrolling 30,000 men and women, none of whom had a previous history of coronary event, and 25,000 of these folks had coronary CT angiograms done at baseline. Just from baseline alone, the authors found atherosclerosis on coronary CT angiogram in 42% of the population. And evidence of extensive atherosclerosis marked by 4 or more segments containing plaque was present in 13% of the population. Now, that automatically puts them into the high-risk category based on the Boston data I just showed. But if there's so much non-obstructive plaque out there, isn't looking for the bad actors that will eventually cause a problem hopeless? I think the answer is no, because we know some things about the plaques that eventually cause problems. Culprit plaques tend to come from plaques that form and gather a large lipid pore, oftentimes with necrotic material within. So they form a necrotic core and cap it off with a thin cap, a thin layer of fibrous tissue, earning the entire thing the name of a thin cap fibroatheroma. And as I had said earlier, I will be calling this TICFA for the rest of the talk. What we understand about TICFAs is that if a cap ruptures or erodes, it will expose the necrotic core to the bloodstream, triggering inflammatory and clotting cascades, resulting in formation of a thrombus on top of the plaque. An unknown number, but probably a lot of these, are asymptomatic and do not cause the patient immediate clinical problems and heal quickly, resulting in a larger plaque, but nothing else. But many of them ends up causing severe obstruction or total occlusion of the coronary artery, resulting in an acute coronary event. The role that TICFAs play in causing culprit disease was apparent in Prospect, which I had already mentioned. In Prospect on IVUS, it is the TICFA plaques that ended up causing the subsequent acute coronary syndrome. In this graph, presence of TICFA was marked by the red bar. Absence of TICFA is marked by the blue bar. And we can see that the larger the TICFA was in relationship to the artery in which it resided, the higher the risk that it became a culprit lesion, up to 18% in very large TICFAs. So how do we go about identifying TICFAs when we're reading CTA? Well, we start with an innate sense of what the plaque looks like, but then we need to go look at some histology features to figure out, is it possible at all to look for it on CT and the way plaque appears on CT. There are some typical features of TICFAs that have been identified and verified from histology. It contains a large necrotic core. There's a fibrous cap that's quite thin. There's expansive remodeling of the plaque, which we typically call positive remodeling. There is neovascularization and plaque hemorrhage in some of these plaques. And there is presence of microcalcification oftentimes within the plaques, in this case termed spotty calcification. Because formation of TICFAs also recruits a large amount of macrophages, it is a lesion that has increased inflammation, which if we were to look for it would require metabolic imaging. Knowing the limits of spatial resolution on CT, there are a few of these morphologic features that seem plausible to be visualized. If the plaque is large enough, with a large enough necrotic core, CT could potentially see it. And the appearance would be that of an area of low attenuation, oftentimes within the middle of the plaque. That's the top left panel in this slide. CT can measure positive remodeling, where the size, the diameter of the vessel at the site of the lesion is in fact larger than a reference diameter just proximal to the lesion. And spotty calcification can be seen as small areas of brightness within or adjacent to non-calcified plaque. The example that I just showed you here is actually a pretty interesting example, so I just want to go over this plaque a little bit. With the red cross-sectional dashed line there, I showed two cross-sectional appearances of that cross-section, and we can see the outward or positive remodeling along with presence of spotty calcification, and I've actually marked the areas of low attenuation with these little areas of orange. But if we look a little more distal into the plaque, we see that with the orange arrow, there's actually appearance of contrast penetration into the plaque, suggesting this plaque has been injured. Interestingly, if we look at this on angiogram, we don't see any of these features. Just based on invasive luminography alone, we probably would have had difficulty telling that a very large bulky plaque is present. The combination of positive remodeling and low attenuation has been found that if it's in a specific formation, results in something called a napkin ring lesion. I'm showing you an example of that here. A napkin ring lesion has a low attenuation core that forms near the center of the lumen and plaque complex marked by the white star here on the top left. Surrounding the low attenuation core, as you can see here, is a higher attenuation semilunar rim, and that's been marked by the red dashed lines. This whole thing has been termed the napkin ring lesion and has been elegantly shown on histology comparative studies to represent advanced TICFAs. Exactly how accurate are these findings for looking for actual TICFA? Comparisons have been made to histology, virtual histology by IVUS, and optical coherence tomography. And the common theme in all these comparative studies is that CT has low sensitivity and good specificity when using these features. Takeaway point is that CTA can find the larger TICFAs, but misses many probably smaller ones. However, if we are able to see these features, especially when multiple features are present, it's probably right. Okay. So with that background, I think we're ready to look at some data of CTA imaging of TICFA features and risk. Just recall very quickly, the three main features I pointed out that we can see on CT are low attenuation for a large necrotic core, positive remodeling and spotty calcification, and then a specific combination of low attenuation and positive remodeling results in the napkin ring sign. So this, I think, was really the study that really got the ball rolling in terms of looking for these high-risk features. In this study, the team was led by Dr. Sadako Motoyama and Jagat Narula. 1,059 consecutive patients who had CTA at enrollment were followed for a mean of 27 months after the CTA. the CTAs were all manually determined to look for presence of positive remodeling, low attenuation, and spotty calcification. In this group, the authors found 45 patients had both positive remodeling and low attenuation, and out of that group, at 27 months of follow-up, 22% subsequently developed acute coronary syndrome. In 820 patients who showed neither features, 4 or 0.5% ended up having acute coronary syndrome. So the difference was dramatic, 20 to 30-fold difference in subsequent event rate. So this study really put up positive remodeling and low attenuation on CTA as high-risk features and demoted the presence of spotty calcification and created this idea of the two-feature plaque. The same team published a sequel study in 2015, this time in 3,158 patients, defined high-risk plaque in a similar way, did the same type of analysis, but this time included obstructive disease as an additional predictor. Follow-up was extended to 4 years. And if you look at the graph on the right, what we see is that patients who had non-high-risk plaque and non-obstructive disease had an acute coronary syndrome rate of 1.2%. Patients who had high-risk plaque and obstructive disease had a much higher rate of acute coronary syndrome at 19%, but not far behind that are patients with high-risk plaque and non-obstructive disease at 15%. So the presence of high-risk plaque in patients with non-obstructive disease made for a 10-fold difference in event rate. In the same study, the authors happened to find 449 patients who had another CTA sometime during the study for clinical reasons. Out of this group, they found that 56 of these patients had evidence of plaque progression. The amount of stenosis on CTA had increased by 1 grade, or there has been an increase in positive remodeling ratio. What happened to these patients were quite marked. These patients had a much, much higher rate of developing acute coronary syndrome, showing that plaque progression was a strong independent predictor of acute coronary syndrome. Plaque progression may look something like this on CTA. This is the left ventricular descending artery of a patient imaged 2 years apart, with the more recent study on the right. Can see that in both the proximal and mid segments of this patient, there has been increase in stenosis severity from both plaques and increase in plaque size. This is a patient at very high risk to have an acute coronary event in the next 1 to 2 years. The idea of rapid plaque progression is not a new one, although previously hints of it had come from invasive angiography in studies of many less patients. This one I pulled was a Japanese study that had 20 patients who had cath within 1 week before having their acute myocardial infarction event, compared to 20 patients with cath who had cath within 6 to 18 months before their acute myocardial infarction event. And what the authors found was that the eventual culprit lesion appears substantially more stenotic when the patients were cath within days before their acute myocardial infarction, whereas virtually none of the subsequent culprit lesions in patients who had cath 6 to 18 months ago were stenotic. Almost all of them were less than 60% in diameter stenosis. Okay, so back to more high-risk plaque. We're getting to more recent data looking at the Scott-Hart study. In Scott-Hart, 1,769 patients had a baseline CT angiogram and they were followed for 5 years. And in this analysis, plaques with positive remodeling or low attenuation were classified as high risk. So just know that this is a less strict definition than the Motoyama studies I had just shown you. Even with that, patients with non-obstructive disease showing either positive remodeling or low attenuation had 3 times the risk of coronary death or myocardial infarction. And patients with non-obstructive disease and high-risk features had similar coronary event rate as patients with obstructive disease, but without high-risk features. A more recent follow-up study of that did a specific analysis of low attenuation plaque burden as percent of artery volume. And in this analysis, patients with low attenuation plaque burden that exceeded 4% of total artery volume showed a 5 times increase in risk of acute myocardial infarction. When the investigative team took a look at the strength of prediction, low attenuation plaque burden was stronger than a clinical risk score, calcium score, and the presence of obstructive disease. Now, if you're not familiar with the assigned clinical risk score, it is a Scottish proven population risk score similar to how we would use the Framingham risk score or the ASCVD calculator. Similar data you can find in the PROMISE trial. In PROMISE, 4,415 patients were in the CTA strategy that were analyzed in this particular sub-study. A median follow-up was 25 months for outcome of death, myocardial infarction, and unstable angina. In this group, the authors defined high-risk plaque as presence of positive remodeling, low attenuation, or napkin ring sign. Again, less strict than the Motoyama study, and they found 676 patients had these findings. Out of a total of 131 events, 66% of them happened in patients with non-obstructive disease. I already showed you this data earlier. In patients with high-risk plaque features, there was an absolute increase in risk of 2% compared to patients without. This risk was marked in women under the age of 60 years old with a 6-fold increase in risk. And in patients with obstructive disease, high-risk plaque was not a predictive finding. So at this point, you may think, hold on, all of these high-risk features depend on having a pretty large non-calcified plaque, and you already told me that CTA can't see smaller TICFAs. So wouldn't this suggest that just having lots of non-calcified plaque without high-risk features can still increase the chance of having smaller TICFAs that we don't see and thus increase risk? And this point would be proven with a couple of studies I'm going to review here. This is the ICONIC study. It is a multinational CTA registry of 25,000 patients who got a CTA and have 3-year follow-up. ICONIC was a nested case control study using propensity matching of 234 verified patients with acute coronary syndrome after the index CT angiogram matched 234 patients without subsequent acute coronary syndrome. The propensity matching was done heavily weighing risk factors and amount of coronary disease severity on CTA. In the analysis of these patients, we see that 65% of patients with acute coronary syndrome initially had non-obstructive disease. This is old news now. I've reviewed this multiple times. With painstaking manual cross-sectional measurement of plaques, the team found that patients with acute coronary syndrome had higher amounts of low attenuation, what they term fibrofatty plaque, okay? And low attenuation are the little dark orange bars with the arrows over them, with fibrofatty plaque, the gray bars with arrows over them. And the patients had increased amounts of total non-calcified plaque. So that would be the combination of orange bars, gray bars, and the red bar, in addition to having increased rates of positive remodeling and spotty calcification. But the authors were able to show that total non-calcified plaque volume was independently associated with risk. Additional supportive information comes from the Paradigm study, another multinational study, this time of 1,255 consecutive patients who were scanned with CTAs at enrollment and then subsequently 2 years, at least 2 years from the initial scan. All of the arterial segments were quantified for plaque similar to ICONIC. And then the team made comparisons between patients who took and were not taking statins. What we see in the analysis is that patients who took statins showed a total reduction in plaque progression. And when we broke the plaque up into its components, all of the reduction was a result of a reduction in the progression of non-calcified plaque. So that's the window, flashing window on the right. In fact, patients taking statins actually had an increase in plaque progression of calcified components. Okay. Again, this is very important. Taking statins reduces the total amount of non-calcified plaque development at the expense of increasing calcified plaque development. This is one of the things we know from doing calcium scans serially in patients taking statins. Their calcium score will increase. We don't know what that really means because it doesn't necessarily mean they're at higher risk for subsequent events. When a deeper dive was done to take a look at the components of the non-calcified plaque, patients who took statins showed a decrease in all components of non-calcified plaque. Fibrous plaque, fibrofatty plaque, low attenuation plaque. At the same time, there was a decrease in high-risk features in patients who took statins compared to patients who did not take statins. Okay, so to review the data I just reviewed, CTA non-invasively identifies some TICFA features and can find large TICFAs. TICFA features on CTA predicts increased coronary event risk independent of presence of obstruction. Higher non-calcified plaque volume predicts higher event risk and most likely represents amount of plaque capable of becoming high risk. Plaque progression was incidentally found to be a strong predictor of coronary risk. And statin therapy slows progression of TICFA features. So how do we actually go about getting these measurements? Here are 3 different left ventricular descending arteries. The reading on all 3 was presence of non-obstructive plaque. But the data I just showed you would suggest that these patients may be at different amounts of risk going forward. How do we get this information across? If we were going to replicate the studies I showed you, that would require our readers to manually comb through CTA to detect plaque features and measure plaque volume. This is an extremely time-consuming amount of work, which I've done before as a fellow. And it is completely unfeasible for clinical work. I remember doing this work as a fellow, and one of my colleagues came by, looked at what I was doing, and said, "Victor, you're doing an ant's work." Okay. In a high volume center, there's no time for an ant's work. In addition, visual detection of positive remodeling and low attenuation has limited reproducibility, and with small features, readers are at risk of missing findings. Recall this study I had referenced from Scott Hart that looked at low attenuation plaque burden as percent of artery volume. This would have required manually going through the entire artery for measurements, a tremendous amount of work. But in fact, that's not what the Scott Hart team did. What they did instead was use an IVUS-proven software solution to detect plaque and look at features of plaque in their patients. In this particular example, you can see that the software has automatically detected plaque, non-calcified plaque in the artery and marked it as red. In the 3-dimensional rendering here, you can actually see that it has detected evidence of low attenuation plaque in these little spots of 3-dimensional appearing orange pieces. This saved time and reduced operator error. The software they used is called AutoPlaque, and it was developed by a very talented, hardworking computer scientist colleague of mine, Dr. Dominique Day at Cedars-Sinai Medical Center. This particular piece of software requires a user to set a few boundaries of the artery of interest. The computer will then do its calculations and then spit out IVUS-validated measurements of all sorts, including all the ones I mentioned. So if you take a look at the right-hand column, you have data on total amount of non-calcified plaque volume, calcified plaque volume, the vessel volume, low attenuation, plaque volume, and remodeling index. Autoplaque is not the only solution that's available at this point. Clearly is a company started by Dr. James Min, and this company has devised a very slick software solution to generating automated evaluation of coronary arteries and coronary plaque with absolutely no user interface needed. All that's needed is to upload the data to a computational cloud. And in this example I'm showing here, the right coronary artery has been extracted, the vessel lumen has been contoured, and all of the plaques have been extracted and segmented. This is then analyzed by quantification and characterization of the plaque, with results also in this case shown on the right-hand column. All of this was done by machine learning. Clearly has also created a clinical engine for patients and clinicians to use. And patients and clinicians can take a look at the data that's been acquired and analyzed and show patients, in this case, projections of plaque progression depending on treatment. This engine in a couple of months will also give patients projection of risk based on some of the data I've shown you. The company and this piece of software is planning to keep its clinical engine updated by continually referencing the core amount of studies that it uses to updated studies that keep getting published. It will also be updating its actual plaque engine by iterative feedback in the patients that it has analyzed. So at MHI, we're now working out terms to partner with Clearly and to try to bring this type of quantitative analysis for our patients, hopefully starting sometime in the first or second quarter of 2021. But the machine taking over doesn't stop there. You are likely to hear this term radiomics more and more in the next few years. And it is a way that really sheds light onto how we as people with eyes fall short in terms of analyzing small structures like plaque. So the definition of radiomics is on this slide, and I'll just read it to you. Radiomics is the process of extracting a large number of quantitative features from medical images to create big data in which each abnormality is characterized by hundreds of parameters indiscernible to the human eye. So here's a study that shows what radiomics does. This team has identified 30 plaques with napkin ring sign and matched them to 30 other plaques with similar compositions, but visually doesn't give you the napkin ring appearance. If you take a look at where the yellow arrows are, those are where the low attenuation parts of the napkin ring are present, and they're absent in the comparable plaques below. But really, aside from that, I personally would be hard-pressed to be able to tell you a big difference, any other big differences between the two groups of plaques. When radiomics is used to analyze these plaques, however, the computer was able to identify 418 features of distinct difference between the two sets of plaques. So radiomics is really pattern recognition for small structures to supercharged level. Okay. Well, that's nice, but why all the trouble? Aren't we just going to treat all these at-risk patients with aspirin and statins? So I think the argument is actually there are a number of other treatments for coronary disease that have been making noise. But because we have had difficulty in really identifying the at-risk patient, we've grown accustomed to accepting a 1%, 2% absolute risk reduction as somehow marking that this treatment is going to be the next hot thing. So for the next few slides, I want you to take a look at the number needed to treat the NNT that I highlight on each slide. This one is a summary slide of the Odyssey outcome study. In this study, alirocumab, which is better known as Praluent, it is a molecule that binds to PCSK9 protein and inhibits its action in blocking bloodstream LDL removal. So overall, alirocumab lowers LDL. Odyssey outcomes compare alirocumab to high-dose statin with high-dose statin compared to placebo with high-dose statin in 19,000 patients after acute coronary syndrome. The combination lowered LDL to 50 and showed an improvement. Patients had less events, but you would need to treat 49 patients over 4 years to prevent one event. Here's the COMPASS trial. 27,400 stable patients with documented coronary disease, peripheral arterial disease, or both were randomized to aspirin plus low-dose rivaroxaban versus aspirin plus placebo. And the median follow-up was 23 months. The number needed to treat to prevent one cardiovascular event was 74 over 2 years, but the number needed to harm over the same time was 80 to cause one additional bleed. Here's the COLCOT trial. 4,745 patients enrolled within 30 days of myocardial infarction to colchicine versus placebo, in addition to standard medical therapy with a mean follow-up of nearly 2 years. Number needed to treat was 59 over 2 years to prevent one ischemic event, while the number needed to harm was 189 over 2 years to cause one additional bout of pneumonia. And then the very recently published LODOCO-2 trial of 5,522 patients with stable coronary disease seen on CAD, CTA, or calcium score, also randomized to colchicine or placebo with a follow-up of a little bit over 2 years. Number needed to treat was 40 over 3 years to reduce one event, but there was a concerning trend of increased non-cardiovascular death in the colchicine group, did not reach statistical significance with a number needed to harm of 167. So what do all these therapeutic trials have in common in this particular lens? The populations that were selected look similar in risk by conventional means, but we didn't really know what their underlying coronary plaque substrate was, and it was likely highly variable, meaning the risk levels in these populations were actually highly variable. And this variability dilutes treatment benefit, making it difficult to produce compelling benefit-risk ratios. If we were able to understand the underlying coronary artery substrate, such as with CTA, we could potentially select a more consistent high-risk population. This would allow trials to better demonstrate higher treatment effect and do so in a smaller population. Consider 2 patients. Patient 1 has a proximal left ventricular descending artery stent, and on CTA has one other plaque, a calcified plaque in the proximal right coronary artery. Patient 2 also has a proximal left ventricular descending artery stent, but on CTA has non-obstructive, non-calcified plaques in multiple arteries, with one of those plaques showing napkin ring sign and 2 showing positive remodeling. By conventional means, these patients for the trials would be considered similar risk and lumped into one category. But the data I showed you tell us that's wrong. Patient 2 is at much higher risk than patient 1 going forward, and one can easily imagine using substrate imaging to tailor treatments for such patients depending on the plaque substrate they have. We could potentially play this out further and take patient 2 and look at what happens to the plaque in that patient, let's say if the patient got a scan 2 years later. In one scenario on the left, there's been a mild increase in total plaque volume, but there's been reduction in non-calcified plaque volume and disappearance of the napkin ring and positive remodeling features. In the other scenario on the right, plaque volume continued to increase, including non-calcified plaque volume, and 2 more lesions developed with positive remodeling. Certainly, on the left, the risk in this patient has changed to a lower risk category, but on the right, there's been aggressive plaque progression despite intense initial therapy, and potentially this can change the way we treat this patient going forward. Certainly not how we're using CTA today in this way of thinking. Using CTA to evaluate treatment effect is already catching on. This is the EVAPORATE trial, very recently published, looking at icosapent ethyl. So in the REDUCE-IT trial, previously published, Vascepa, that's the brand name for icosapent ethyl, lowered triglycerides and reduced overall cardiovascular death and myocardial infarction. EVAPORATE looked at 80 stable patients with coronary disease by cath or CTA, and they had to have high triglycerides and had to be on statin therapy. Patients were then randomized to Vascepa 2 grams twice a day versus placebo. Patients were all imaged with CTA at baseline at 9 months and 18 months. And as you can see on the graph there on the right, patients treated with Vascepa showed components of non-calcified plaques, all components of it decreased with treatment. Those are the blue bars, compared to placebo, where all components basically increased in the red bars. So this approach shows us that at least one of the mechanisms by which Vascepa reduced event rate was by reducing the types of plaques that eventually became culprit plaques. There are multiple nanoparticle-based molecules being investigated for treatment of arterial atherosclerosis. And I would anticipate serial CTA imaging for plaque substrate being an integral part of evaluating these molecules when it comes to human treatment testing. Okay. Moving on to some uncertainties. Certainly, there are many uncertainties that need to be answered before we can roll out this type of plaque characterization for patient use. Some of the questions are smaller in scale. I just list some of them up here. What are some of the best cutoffs for low attenuation plaque burden, positive modeling, non-calcified plaque burden? What is the optimal time to identify rapid progressors? What is the true clinical utility of monitoring plaque change? Does plaque characterization matter at all in patients with bypass grafts who have altered flow profiles in the native coronary arteries? Does it make sense to do CTA routinely after acute coronary event to identify at-risk plaque, similar to the way that Prospect did its IVA study? Some of the questions are much bigger in picture. Assume that we do roll out plaque characterization for our patients. What do we do about the definition of coronary artery disease? Right now, it's heavily dependent on the presence of obstruction. Do we not need to change this definition? And are we ready to quantify risk using direct plaque imaging instead of non-imaging surrogate algorithms? So this last question gets to the thorny issue of whether or not to image patients without symptoms and without coronary disease history. Right now, CTA imaging that gives us plaque information are happening almost virtually in patients who presented with symptoms and are looking for help, or they have presented with an acute coronary event. What do we do about the patients who don't have symptoms and have no history, as shown to us by the SCAPAS registry from Sweden? It's not an easy question to answer. Right now, I don't have an answer for you. Okay, time for conclusions. I do hope you take away a few things from this talk. Starting with the stenosis paradigm for coronary artery disease does not address the substrate of non-obstructive TICFAS, which causes the majority of acute coronary events. Coronary CTA is the one non-invasive test that can be safely used in large populations and routinely provide information about non-obstructive plaque. Cohort studies have consistently shown CTA capable of finding TICFA features that dramatically increase the risk of acute coronary events. Software solutions that detect and measure high-risk plaque features are going live, and we need to figure out how to use the information to improve patient care. And finally, CTA characterization of coronary artery plaque is positioned to help find the highest risk individuals. And if used smartly, can enhance treatment trial patient selection, and most importantly, drive customization of matching our patients to their appropriate treatments. Thank you. Happy to take any questions. Oh, hey, Mamas.
That was amazing, elegant presentation. Really appreciated it. A couple of questions. Prospect 2 just presented at TCT and shows very similar findings as you said. However, in Prospect 2, it was less than 10%. The highest risk plaques, the ones with lipid and local plaque burden, was like 7.7%. So the individual plaque predictive was not, and that's with 3-vessel imaging, right? With intravascular imaging with near infrared. So still, even if you see that, the risk is significantly more, but still on a per patient basis, it may be still relatively low. It's not like a 50% or 100%. It's going to be like 5-10% risk. So that's one of the challenges, how to incorporate in the practice. And then until we get clearly, I mean, right now, when I get a report, will I see any of this about the patient? Let's say a patient comes in and gets a scan from you. At this point, do you present anything to us about the potential risk for events to consider PCSK9 or Vascepa?
Yeah, so Dr. Plaque has asked several very important, good questions. I think there were 3 in there. I'll try to tackle each one of them. So the first one is, yes, we're identifying higher risk patients, but the absolute risk increase is still not very high. And that is just because there's so much plaque out there. Because there's just a lot of plaque out there. And when we study with IVUS, we're seeing lots of little TICFAs in addition to larger TICFAs. Certainly, we need more data probably to figure out, can we get it so that we can identify a patient who is at, say, 25% risk of having their event in the next couple of years. There's a hint earlier in ability to find, perhaps in such patients, if we find plaque progression in the interim before the time they have the event. But I would argue that if you find patients who have a 7 to 10% risk in the next 3 years of having their event, that is substantially higher already than the type of patients we're seeing in the clinical trials that are out. And we would be able to detect a better effect from treatment, even if that is the number we're working with. The second question is, what are we seeing right now in terms of plaques in the reporting from CTA? And right now, we are not routinely giving even semi-quantitative measurements of plaque on our reports. You can tell if patients have multi-vessel plaque because it'll be specified under the specific arteries whether there's plaque in it. But I think an argument can be made that we should probably start just saying how many segments of plaque we see, because there's data for 4 or more segments putting the patient at substantially increased risk compared to less number of segments. But right now, we do not have that. We could potentially do that until we get clearly rolling. And then we certainly need a new way of thinking about conducting our trials with more baseline imaging data if we were going to use this to tell us how to tailor specific treatments. And I think that is starting to happen. I didn't reference this study, but colchicine has also a different study that looked at what it did to the plaque on treatment with serial CTA imaging, and it did something similar to Vascepa. The plaque changed in morphology and the non-calcified plaque decreased in volume. But I think we would need to revamp the way we think about doing clinical trials so that we can use the imaging data and say, hey, you've got this type of plaque profile, and if the person had serial imaging, it's changed in this way, you fit the type of person who should be on combination colchicine and rivaroxaban in addition to our additional usual treatments, for example. John.
That was as good a talk on the subject that I've ever heard. Very comprehensive.
Oh, thank you.
A couple of issues, just in answer to some of that. The data for outcome risk relative to TICFA finding on CT is most in the early phase, in the first few years. And then after that, it's really about plaque volume.
Yes.
And so it kind of falls apart. So I wouldn't be surprised that prospect later in follow-up doesn't show many specific lesions. Also, in the ICONIC trial, there were a number of sites that have TICFA and being able to predict which one will rupture is extremely unlikely. So you're probably identifying the patient who's going to develop and not the site. So preventative stent placement or something is not a great idea.
Yeah.
Now, for thinking about where you think we're going to be in the very short term, will you think we should screen people without not just a calcium score, but use an AI program like Clearly to look at people without symptoms? And are you interested in getting part of any of that?
Okay. Two questions from that. One is, am I thinking that we should be scanning patients without symptoms, not just with calcium scans, but with CT angiogram? So this, as a concept for the field, is a little bit of a taboo topic. And I think there's some argument to be made that if we are doing colonoscopies in patients at age 50 routinely across the board, we should think about looking at the substrate for something that kills people even more in coronary disease. And I think the field for CT is uncomfortably digging at that at this point. A place to start, perhaps, would be in the same kind of patients that the lipid treatment trials have gone after, which would be these patients with really aggressive family histories or familial hypercholesterolemia, where we may want to start imaging these patients before they develop symptoms because they're at such high risk to understand their substrate. And second is, would I like to be part of this? Being at this center, I would love to be part of this. In fact, the SCAPAS registry was something that I had pondered and discussed a little bit at Cedars before we went, but it requires such a giant effort that just a few centers wouldn't be able to do what a country did, like Sweden.
Outstanding.
Joel. Oh, yeah, no problem. And then Scott next, I think. Yeah. No, you're good, Joel.
Okay.
Yeah.
No, outstanding talk, and I, really, have learned so much from you since you have come, and it's phenomenal to see the development into the AI. And going back to that point that was raised about the asymptomatics, I don't think we can ignore. Scott Hart 2 should be coming out in the next couple of years, and we don't have its asymptomatic patients randomized risk factors versus CTA, but we don't have a calcium score arm.
Right.
And can you comment, is there any evidence that, the use of contrast and putting them through adds much to the risk stratification? I'm a believer that it might, but do we have any solid data to this point?
I don't, I'm not sure that I am most completely updated on the comparison, but as of 8 years ago, 7, 8 years ago, the comparisons that I knew of that directly looked at this suggested in asymptomatic patients, there was not a clearly demonstrated benefit by doing CT angiogram compared to calcium scores in completely asymptomatic people. That was in the confirmed registry. The issue, I think, comes about in how selective are the calcium score patients in comparison to the way that we want to potentially select patients for CT angiography. The concerns of giving contrast and giving radiation for CT angiography, I think there is still a little bit of a myth on the risks associated with that compared to, because it's based on thought patterns in 2005 to 2010. The amount of radiation patients are getting with CT angiograms now are much less, comparable to patients who get an aortic CTA. And patients may be getting those CTAs every 1 year, every 2 years to monitor their aortas. And multiple more contemporary studies have shown that even in patients with stable chronic kidney disease, that's pretty advanced. Contrast injection doesn't increase their risk of permanently injuring their kidneys by very much. So I think the safety profile of CTA, I would say, is at or perhaps less than giving conscious sedation for a patient with colonoscopy. So I wouldn't think of safety as a result. I think efficacy and risk identification is a bigger issue.
I just have a quick question.
Yes.
That was very nice presentation. In patients with myocardial infarction and non-obstructive coronary disease who've had a luminography, as you say,
Yeah.
should they also have CTA?
Yeah, so I brought this up as whether or not we should try to understand what kind of myocardial infarction patient this was based on the substrate they had coming in. I would say that if we were going to start treading down the asymptomatic disease patient road, this would be another area to start with, to basically do prospect using CTA in large populations. That group, along with the familial hypercholesterolemia group, for example, would then lay the groundwork for looking at expanding the use if the signal pans out. Yes.
Thank you. We have several online questions. The first of which, in looking at TICFA, have any studies done a deeper dive on patients who have high-risk family histories and establishing a baseline? And to clarify, they're referring to patients that are asymptomatic and establishing a baseline plaque volume as acceptable or risk stratifying them, and to still consider their high-risk family histories.
Okay, that's 3 questions. Okay. Question number 1 was about TICFA, right? Can you repeat that part for me?
Yeah, so in looking at TICFA, have any studies done a deeper dive on patients who have high-risk family histories?
Right. So I don't know that, but I suspect the SCAPAS trial, the SCAPAS registry will give us that because so many patients were imaged in that cohort. And then the second is getting a baseline of plaque volume in patients with family history. I think the bottom line is we're treading into territory that we're not comfortable with yet, and we haven't gone down. So I don't think we know. I think the signal suggests that it would be a group of patients to start with, but you would be probably committed to imaging them at least one more time, sometime down the line, to understand plaque progression if you're going to do it.
Perfect, thank you for that. The next question is about Clearly. Will Clearly incorporate radiomics?
Clearly does not do radiomics. There are actually just a few teams in the world that I'm aware of who are working on it, really one dominant team. And they just started, they're scratching the surface.
Excellent. So the last question is from Dr. Bradley, who says, great talk. Fuster, Nissen, and Libby have all written eulogies for efforts to identify at-risk plaque as it relates to patient risk assessment. Why were these eulogies written too soon? And is it automation and big data that will offer new promise?
Okay. I never want to say that Fuster, Nissen, or who am I missing in that group? And Libby are wrong. But I think John's point earlier is well taken, is that CTA is showing us with substrate imaging the at-risk patient and perhaps not the specific at-risk plaque. And a patient with lots of non-calcified plaque, for example, probably has a field defect. There are many areas in this patient that could eventually cause the culprit event. and trying to look for a specific area may be fool's gold. Some of the data that had been shown looked at a particularly large tick fuzz that probably was much more active. And therefore, Dr. Motoyama's team found that they actually correlated to events later. CTA could potentially do that in a much smaller number of patients. And then I agree. I think with Dr. Bradley's assertion that I think we're going to big data. Radiomics is big data. The way we're going to feed back patient plaque information to automated processing is going to generate additional big data, and that will help us refine what we're doing.
What about image quality? No one ever talks about this because we only analyze images we can analyze.
Yes.
How would you think about this?
Well, image quality is super important, especially when it comes to plaque imaging. If you ask any experienced CTA reader, they will say that a poor image quality with lots of image noise can mistakenly get processed as plaque with computerized algorithms. We've seen that happen with our FFR CT calculations, for example. The computerized algorithms are being developed more and more to account for that and to be more tolerant of that. However, I would be very cautious in using plaque characterization going forward, and I would limit it only to high quality imaging at this time. Is that it? Thank you, everybody.